This is where we put electrodes on the chest. It's called a 12 lead EKG. It is not 12 leads that gets put onto the chest. It's where it picks up the electrical activity that the heart is giving off. And we pick up 12 of those leads for us to read. There's, I think, 10 leads that go on. 1, 2, 3, 4, 5, 6, 7, 8. Yeah, there's 10. Okay, 10? No, it says 12 leads, but that doesn't mean 12 leads go on you. Only 10 patches go on. And it looks at your heart 12 different ways. That's why it's called a 12 lead. Because you have arm, 1, 2, 1, 2, 3, 6, 10. See? Echocardiogram. This is where anything that you see echo anything is usually an ultrasound. This means that they use a transducer and they bounce sound waves, and the sound waves in a particular area will pick up that form that it is bouncing off, or extra forms or problems that could be in line. Some of them now are so technical that they're in color, and they can see arterial, venous, and they can see problems with that. So all you need to know is that it is a transducer that transmits sound waves, and it shows those in images. Holter monitor. Yes, you do need to know about a Holter monitor. Holter monitor is used for cardiac problems. It is a recording of the EKG that your heart is doing, or your heartbeat, for about 48 hours. That means 2 days. They put these same patches on you for these 2 days, and it records what is occurring during situations that you may be doing: eating, sleeping, getting up and walking, going to work, whatever your activities are of that day, and you've been having some problems or some chest pain or some palpitations during that you've gone in to complain to the doctor about, they will then order this Holter monitor. Now, what is usually asked about is your nursing interventions and or your teaching to the patient regarding this. Because they are stickums on, they can come off easily. So we don't want the patient going in and taking a shower. So they have to give themselves a sponge bath during that time for those 2 days. Yes, they have a diary, a written diary that they write down what they're doing at certain times during the day so that they can correlate what they were doing with what the EKG showed at that time. If they were out running and they got some chest pain, they also, on the little machines, have an event button, or they push the button if they start having chest pain, palpitations, shortness of breath, anything that's abnormal. They do that, and it records that they were having some problems, so when the person who looks at this recording can see during this time they complained of palpitations. Oh, I see, they were having some abnormal beats, and they go from there. So, sponge bath, yes, the event button, And that's what you need to know for Holter monitor. Thallium. Thallium is also talked about on 310 in your book. This is where we inject. It's invasive, and we're going to inject, and we need to make sure what then?
Informed consent?
Pardon?
Informed consent?
Well, we have to have a consent, yes, for sure. But what else do we ask about if we're injecting a isotope?
Allergy.
Shellfish allergy or allergy to iodine. Okay, anything that's being injected, your answer may be check for allergies. That's common sense, that's a nursing process. What occurs during exercise is if there is an area that is been harmed or is irritable, it will generally pick up this thallium dye, and it makes it a white area. We usually then call that a cold spot. We can do it for bone, which you learned about in musculoskeletal. We can do it for other problems, brain, throughout the whole body. It goes into the circulatory system, and usually it settles into the area of damage or destruction. We do it also for the thyroid, we'll find out, with endocrine. So, teaching, we teach that the radioactivity that they get is very small. It's not going to hurt anybody at all, not even going to hurt them, because it's specific for one particular area, and that's the heart. It's usually gone in hours, but any patient that gets a injection of some type of dye needs to, in nursing interventions, needs to increase their fluid intake, because the way we get rid of it is through the kidney. And if we increase our fluid intake, then we increase the flow to the kidney, and the kidney will eliminate it. Okay? Cardiac enzymes. Any other teacher who'd be leaving would just say, bye, take care, I'll see you when I get back. Here, I'm saying, no, you're coming with me. All of you. All right, cardiac enzymes. What I want you to know for this test is cardiac troponin. Cardiac troponin is a specific cardiac enzyme that tells us, is there damage within the heart itself? There are other enzymes like a CPK. CPK we can do that tells us muscle damage, but it doesn't tell us where was that muscle damage. So it could have been a shot you gave the patient, it could have been a fall, it could have been liver, it could be another organ, but it's not specific enough. Yes, it tells us that there's muscle damage, but it doesn't tell us where, whereas the troponin does.
Could you please tell us the page number, Ms. Lee?
I have to find it.
Page.
Troponin 1, 311, last paragraph. Under serum and cardiac markers, I'm talking about all of those. CKMB, troponin 1 is the last paragraph. Do you have it?
Yeah.
All right.
Thank you.
It's over here on this page, 311. Okay.
The last paragraph?
Last paragraph before of the first column.
Okay, thank you.
But it also talks about other markers up here. It talks about the serum enzymes, troponin 1. It's an important screening diagnostic criteria. We've also got the CK. Remember, I was saying CK is okay, but it doesn't tell us specifically. But we now have CKMB. that is specific for cardiac. When cardiac cells die, they give off their enzyme, and that's what we check for. You will have to read this area, but essentially, I'm giving you what you just need to know now. We're really going to go into CKMB, troponins, later on when we're talking about PAD or MI. And unfortunately, that's going to be when she's giving you the lecture. And hopefully, she has looked at the test first to give you that. Oh boy. Okay. The cardiac muscle contains proteins called troponins. Essentially, this is what this paragraph is going to talk about. These then troponins are found within the muscle, and they control that heart muscle. There's also the myoglobin up at the top of 311. This also gets released into the circulation soon after. Now, you're lucky enough that your LVNs, you don't have to know specifically the times that these elevate within. We do as RNs. We do also in the emergency room if you choose to go into the emergency room, because there are different time elements for these enzymes in their becoming raised and coming back down to normal. And when we see these levels, we can know then, did this MI just happen, or has it been a few days, or is it occurring? Okay? And that's why we do these levels, and we will do serials. That means not with a C, but with an S. Serial readings, in other words, every couple of hours we'll draw blood to see where their enzymes are at. Okay, troponin 1 is sensitive indicator for myocardial damage, and it is used to diagnose an MI. You need to know that. It usually elevates within 4 to 6 hours after damage and up to 7 days. I believe you need to know that one in particular for the test, the troponin level. It's in my notes, and it's in the book. 2 places. It's probably in your NCLEX book also, the same thing. Now, when troponin levels are elevated, we usually put the patient on bed rest. The reason why we put them on bed rest is not to increase the demand of a weak, sick heart muscle that has been damaged. They don't remain on complete bed rest because we know that stress also causes the heart muscle to strain. So, in one of the questions, it's probably going to be in relating to troponin levels. What do? You put the patient on bed rest. In other questions, it may refer to the MI, but we can allow the patient to get up or to the commode, which is right next to their bed. The reason being is trying to use a bedpan to go, number 2, is not very comfortable. If it's a female, using a bedpan to urinate, not very comfortable because it goes down the back of you. For a male to use a urinal, not too bad. But if they want to have a bowel movement, usually they need to get up to the commode. Not only that, in using a urinal, if it's an older gentleman, usually they have to stand, so maybe getting them to the side and dangling. So one of your answers could then be a commode or up to a chair. okay? So you know the difference? You heard the difference. If it's troponin related, it's probably bed rest. If it's MI or anything else, it may be the answer of chair or commode. Blood lipids. Blood lipids are on page 313. Hyperlipidemia. Okay? Lipids include triglycerides, cholesterol, and phospholipids. Triglycerides are found in very low density lipoproteins. That is LDLs. Cholesterol is found in low density lipid proteins. These are not good for you, LDLs, because of the cholesterol and because of the triglycerides. High density lipoproteins are half and half. They're half protein and half phospholipids, and some cholesterol in them. It is during the nighttime that the blood or the liver, and I think you should have learned this in GI, the liver gets the blood and cleans the blood of the cholesterol. That's its job. It's supposed to break it down and make it usable, instead of the cholesterol becoming lipids in your vessels or fat cells on your body. If we have high levels of LDLs or low density, this is the precursor for CAD, which is coronary artery disease. You need to know that. You need to know that LDLs are responsible for most of our coronary artery disease problems. HDLs have a protective effect for CAD, which is coronary artery disease. That's because they carry the cholesterol to the liver for metabolism. That means you now know that when we start talking about drugs that lower the cholesterol, lipids, when we get to those, we know then that in order to help the liver, we are not going to give these in the morning. We're going to give these drugs in the evening time. And we know that if it is to get the cholesterol to the liver for metabolism, then there is a property behind it that is liver destructive. And we have to keep an eye on the liver enzymes for this when they are on these lipid lowering drugs. You need to know it forever because it's going to be asked of those drugs when we get to it. Any questions about this? HDLs are good, LDLs are bad. Essentially, that's what you need to know. And you need to know when it's metabolized. Angiograms. Angiograms are concept. Any test that has to go through the circulatory system, it's spelled wrong. It's all right. I know how to spell that one. Vascular. The vascular system means that the aftercare or the nursing interventions after this are always the same. Whoa, got a little dizzy. Always the same. It doesn't matter if they're looking at the heart, if they're looking at the brain, if they're looking at the leg for circulation, if they're looking for blood vessels. It doesn't matter. As when we enter this vascular system for diagnostic purposes, the nursing intervention afterward is going to always be the same answers. Differently written, differently stated, but the same. 7 P's. That means you need to know what those words mean. Sensation, color, pain. You all know your 7 P's?
Used to.
Pain, pulse, pallor, paresthesia, paralysis, puffy, polar. So, they're not going to say paresthesia. They're going to say maybe numbness, right? Or sensation. Paralysis. They're not going to say paralysis. They're going to say inability to move, not able to wiggle the toes, whatever it might be as we went through. Puffiness. They're not going to say puffiness. They're going to say edema. Or they're going to say pitting edema. Pain. Yes, pain. But are they going to say pain? Well, they may say pain. Pulse. How do we know pulse? We're feeling for a pulse. Then, a dorsal pedis or a posttibial. Pallor. That's going to be looking at it. What color is it? Pale. Cold. Polar. Cold. If I want to know for circulation of this that goes along with pulse, it's going to be your capillary refill. Because we just learned today, capillary refill has everything to do with circulatory system. The same thing is also going to be for if we went into a big vessel for this test, then the complication with this is going to be hemorrhage. So what do we look for? Nursing intervention from the hemorrhage over there is going to be, is there a hematoma? Is there a sandbag or pressure to the area to stop the bleeding? Is there bleeding? Check the dressing. Do we want to have them do whatever they want to do that could possibly open this up to hemorrhage? No, we don't. So they need to stay flat for a certain number of hours. They can't bend their leg. They shouldn't really even be moving their leg. How are we going to move them in bed? We're going to log roll. These are all signs and symptoms that, or nursing interventions that you learned back when taking care of a cast. Because if the cast becomes too tight, it affects these. And what do we want to do with the cast? We want to elevate to decrease the edema and all the rest. Anything having to do with obstruction of the circulatory system is going to have these answers.
Compartment syndrome.
Compartment syndrome, there could be compartment syndrome, but that would only be if there is bleeding into the area of the femoral area, bleeding into that and now compressing down. The pressure of the bleeding into that area is compressing that artery. So angio is using dye. What's your number one?
Allergies.
Allergies. It's not fish. It is shellfish. Okay? Or iodine. Why do we do an angiogram? Well, we may be looking for a clot. We may be looking for peripheral vascular diseases in our extremities. We may be looking for vessels that we could graft. Whatever it is, this all remains the same. Your nursing interventions, and I have them down here. Assess for allergies. Yep. We keep them NPO. Does anyone know why?
Yeah. Throw up.
They may throw up. Yes, because they get this flushed feeling. And they may become nauseated and vomiting due to the dye itself. And we don't want chunks coming up, do we? Because then what is our concept going with? Yes, it's going to be aspiration, it's going to be airway, and it's going to fall underneath the safety. Okay, do you see where it's going back to the concepts? All right, the patient may feel hot. There is going to be some questions in this area. The patient may stay for several hours after. We're going to be watching for allergy reactions during that time. We're going to be checking their vital signs, and we're going to be checking for hemorrhage. There is no flexing or moving of the leg. We do log roll. We do check for a pulse at the injection site and below. So if it's of the femoral, you're going to be checking popliteal, you're going to be checking pedal, and you're going to be checking post-tibial. Does everyone check those anyway when you do your assessments?
Yes.
Okay. You should. You should check what this one is with the pedal and the post-tibial. A lot of times you may not be able to feel the pedal, but you can feel the post-tibial, and you know that they're getting good circulation then down there. Encourage the patient to drink fluids. Oop, forgot that one. Increase fluids. Now I know I've taught this for a long time and I've been a nurse for a long time, but did you see how it just rolled out of my mouth, all of this, and it always remains the same? This is what I want for you. Okay, cardiac cath. Cardiac cath is the same thing as an angiogram, except we're looking and injecting the dye through the angiogram and looking specifically at the heart. So that's why it's called a cardiac cath. So all of this applies. It's going to look at the, we're able to put a line up into the heart and check the pressures that are up there in the ventricles or in the atria. If we want to look at the right side of the heart, how do we get there? What vascular area do we need to go into?
Superior vena cava?
We can go into it through the superior vena cava, yeah, okay. What I'm getting at is, if I'm looking at the right side of the heart, what vascular access does it need to be? What does it need to be, artery or vein?
Oh, it's vein.
Vein. If I want to look at the left side of the heart, how does it have to be?
It's artery.
Artery. That's why they're in big vessels here, moving the catheter along its way to come up through the aorta to go in through the aortic valve. And we talk about this. It talks about fluoroscopy. Fluoroscopy is where the machine is over and the doctor has a pedal and he injects the dye, the fluoroscopy goes on, and you watch this dye go throughout the circulatory system and into the heart. And he's able to do this. So radiation is going on for those seconds that he's got that there and you're looking up there at the TV screen. When he takes his foot off, there is no radiation at that time. Okay, right-sided, I'd read over. This is looking at chambers. Left-sided, we're inserting it through the femoral artery or the brachial, and it goes up into the aorta. The nursing interventions that you see on that next page are the same that we just went over. NPO, awake for the procedure, flushed. Table moves. There is a question about what to expect during a cath, a cardiac cath. That's the table's going to move. Why? Because he's got to move the patient underneath the machine for the fluoroscopy. Is it cold? Yes. Why is it cold in there?
Constrict the veins.
It's to decrease
The
the use of oxygen.
Oh.
Cold areas, yes, vasoconstricts, sense thereof, decreases the amount of energy to be produced. Unless the patient starts shivering, and then they're really overproducing at that point. Please do read my notes about complications. Again, there is firm pressure. You're checking for hemorrhage and hematomas. A pressure dressing or a sandbag is used, vital signs. And check the puncture site frequently. They can't be moved or flexed. And the questions aren't going to ask that way. It's going to be in the scenario that says, what is wrong with this picture? Okay? It can be in that scenario that goes along with these signs here that says something is wrong. You are not putting the patient's head of the bed up. You're not giving them liquids right after, because it may be difficult to give somebody who's laying flat liquids. Do you see how the questions can possibly take you down the wrong pathway? So understanding these answers or understanding the information that I've given you is important. That's where students make and will come back at the instructor for, well, you said, but this said, yes, we did, but this is saying something else. All right, the last part here is CVP. CVP stands for central venous pressure. What are we looking at for that pressure? What part of the vascular system? Is it artery or venous? Venous.
VV, yeah, Venus.
In many questions, they're going to put arterial, some type of test, or a venous Doppler. If you know that we are dealing, or the question is dealing with venous, then don't put arterial Doppler. Put down venous Doppler. Okay? Read your answers as you do. This is not just for this next test, it's for all the tests. Giving you valuable information here. CVP, central venous pressure. So I am looking at blood flow coming back to the heart, correct? There's his little old heart. Okay, central venous pressure means blood coming back to the heart, because we know that if it's too much and we have a problem with the heart pumping it all the way through, that the biggest problem that's going to happen and kill this patient is left-sided heart failure, which is then pulmonary edema. We don't want that to happen. So we check central venous pressure to see how much is there. What usually it is it's an IV fluid. It is through, if I'm saying central venous pressure, is that just an IV here?
Through the vena cava?
It's up into the atria here. Okay? It's checking the pressure of how much fluid is coming into that right atrium. And it's venous. So we've had to put some type of central line, either in the subclavian area here, in the femoral area, through the brachial area, but wherever it is, the tip of that catheter is up into the right atrium. We have IV fluid that comes down and into the patient's arm. It has a manometer on it. This manometer has little points. What we do is we find out where the heart is, and depending on which side, it doesn't really matter which side you have it, but the heart usually sits halfway between the diameter of the side of you. So you position the 0 right here at the part of the body as the patient's laying down flat. You open the valve to put fluid down into this and put it into the manometer. You position it over here at the side of the heart, about where the atrium would be, and we turn the valve so that this fluid now flows into the atria. If there is too much fluid in the body or in the atria already with blood, this is going to be high. It's going to register high. And it's going to register high and say, too much fluid, we better get rid of some of this fluid because we know the consequence is left-sided heart failure. So we call the doctor. It also may be that it's low, too low, which means then if it's not in the normal range and it's low, it means, is there enough fluid in the patient? No, it means they are dehydrated. We need to let the doctor know and get more fluid into the patient. So too high, too much fluid, too low, give fluid. So in essence, it is measuring preload. Remember we talked about preload, of which we never talked about afterload, so I have to talk about that. Preload, what was preload?
Heart stretching to compensate for excess fluid.
This stretch of the ventricle that is needed to push the blood out into the vessels. Both sides. Either this to the body on the left side or this on the side of the right side. It's whatever that stretch is that that ventricle has to accommodate to in order to push with force the blood out. Afterload is not only the stretch of it coming outward, but how much increased peripheral vascular resistance does it need to push against? If we are in a vasoconstricted state, this ventricle, with its stretch of 100 cc's instead of the 60 to 80, is going to have to give more force towards that contraction to get it past this vasoconstricted state that's making it stop. So it's going to have to push farther or push harder. And so we give medicines, and this is why you need to know preload and afterload, because we give medicines to help with preload. Lasix, get rid of that fluid so that we don't have that stretch so much. Or we have medicines for the afterload that are going to vasodilate or get rid of fluid as a diuretic to help with the afterload stretch. So that's why we need to know what both of them mean. With the CVP, it is giving us an idea of how much volume of fluid does our patient have. Too much or too little? In layman's terms, that's all you need to know, but find the wording that goes along with too much or too little. Those are going to be fluid deficit, too little, or fluid overload, too much. Afterload, the amount of ventricular force needed to open the valves and eject the blood. And it's on my paper, preload and afterload. Last page. You need to know it. There's a question about each of them in defining it. Now, let's review about those nice stockings, because there's questions about it on the exit exam, so you need to know it 6 months from now when you're taking that lovely exam. They also ask about it on NCLEX, the nursing interventions about them. Anti-embolism stockings, they should be 1 to 2 inches below the knee. They should not be rolled down, because it's going to cause then, instead of helping with circulation, it's going to cause venous stasis below that. So we don't want the obstruction of circulatory perfusion. You need to remove these stockings twice a day for 20 minutes. That's the concept. That's the answer. It won't change from that. It will always be that. First thing getting out of bed is the usual time that we put them on, and we take them off or put them back on at nighttime. So twice a day, they need to be removed and put back on. I'm done. Now, modifiable. I'm not quite done. I'm done enough, but I need to go over. There are some questions about modifiable and non-modifiable risk factors. They're talked about on page 312 and 313 and 14. Non-modifiable.
Age,
Yep.
family history,
Family history, gender,
ethnicity,
culture. Can't change culture, for sure.
those are the non-modifiable.
It's cold in here now, huh? Well, too bad. 'Cause bring a jacket then. All right. You probably should remember what your modifiable and non-modifiables are. Non-modifiables are going to be, one of the ones that goes into non-modifiable is diabetes. Diabetes is a because we already know that due to diabetes, you're going to fall into some problems with it. Now you can try and control it with diet, weight, stress, exercise, and those things, but diabetes is going to do its job on you. So with the non-modifiable, if we're talking about family, who would be our family that we'd be looking at for?
Parents,
Pardon?
parents,
Parents?
grandparents,
You can look at grandparents. Your siblings, yes. Your brothers, sisters, but not your aunts, uncles, cousins. Okay? It has to be immediate. So, please remember that part of it, that it is your siblings that you look to, also your brothers, your sisters, and that should be all, right? And parents and grandparents, but not aunts, uncles, and cousins. Questions in that area try and trick you, more or less. So I don't know if it comes in now or if it comes in another test. Just remember what I've gone over here with you. Diabetes, I guess, did fall into, they've put it here into a modifiable factor, but we can control it. We can't change it once it becomes, unless it's type 2. We can really, really control type 2. But if it's type 1, you can't. Okay. Stress and psychological, you should be aware of. Pacemaker. I said that the pacemaker was used for what type of problems?
bradycardia.
Bradycardia. We're going to find later, we'll talk more about pacemaker, but there is a question about pacemaker and knowing that portion of it. Any questions? Overwhelmed? Did you study somewhat last night when I made it mandatory to do your stuff?
Yes.
Yeah.
Yeah, I think you should